with me here in my heart, here in my heart. You've only got one mama, you only got one pa, you've only got one life to live, no matter who you are. You can go the whole world over, every city has its dawn. But everybody living has one place where he was born. And mine is Kenya, so warm and wild and free. You'll always stay with me here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart, here in my heart. Only got one childhood and the memory that springs when you see your house, the tree you climbed, and all those precious things. The faces of the friends I had, the images that form. When I close my eyes in the land I love, the land where I was born. My land is Kenya, so warm and wild and free. You'll always stay with me here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart, here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart, here in my heart. only got one mama, you only got one pa, you only got one life to live, no matter who you are. You can go the whole world over, every city has its dawn, but everybody living has one place where he was born. And mine is Kenya. So warm and wild and free, you'll always stay with me here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart, here in my heart. Got one childhood and the memory that springs when you see your house, the tree you climbed, and all those precious things. The faces of the friends I had, the images that fall. When I close my eyes in the land I love, the land where I was born. My land is Kenya, so warm and wild and free. You'll always stay with me here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart. Here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart, here in my heart. Only got one mama, you only got one pa, you only got, you only.
Good morning, everybody. Good morning. If everyone can be seated. Thank you so much, those in the room and those online. I'd like to welcome you to the inaugural Kenya One Health Conference. And first, I'd like to invite my colleague, Dr. Bernard Bett, to start introducing the day. Thank you.
Yeah, thanks a lot, Lian, and really great pleasure to see all of you online and also in the room. So today we launch, we commence our Kenya One Health Conference. And I still have two things only to do. One is, of course, to welcome you, but also to give you a short presentation, which clarifies what ORECA, which is the host project for this conference, does. So I think let's then move to the next slide, Geoffrey. Would I do it? Oh yeah, I have it here. So of course, my name is Bernard Bett, as Lian has said, and it's an echo. Yes, and the team leader for the One Health Center in Africa. This is a project funded by BMZ. And of course, it's led by ILRI. And I wanted first to say who is ILRI before we come to the project. We know ILRI is one of the CGIAR institutions which uses agriculture research to reduce poverty. And it's one of the 15 CGIAR centers which all constitute that CG institutions. Overall, we have up to 8,000 scientists, researchers, and technical staff who coordinate in one way or another to implement research on crops, livestock, environment, and many other sectors. Coming back to ORECA, of course, this is led by ILRI, and it's now in its second year of implementation. It was funded basically to do four main things. Or before those four main things, the main focus is to enhance health of people, livestock, environment, and of course, wildlife. But it has four main aspects. One is to support One Health initiatives, which have been set up in the sub-Saharan region where we are focusing on. And also its aims at building capacity on One Health through studentships, also by working with communities and also by working with government institutions. The third one is to continue working on ongoing One Health projects, and these are mainly applied One Health research projects, which aim to seek solutions on the ground. These are applied research, which then helps to formulate policies and practices, which the fourth component of that objective is on. Just to come back closer into the specific activities, we have classified our work into four thematic areas, and we call them food safety, emerging infectious diseases, neglected zoonosis, and AMR, that's antimicrobial resistance. Although these are thematic areas, we know there's really so much overlap. There is so much coordination across these thematic areas, but we decided to classify them into those pillars for the sake of management and implementation of activities. And they also specifically focus on specific research questions, which sometimes are not necessarily cross-cutting in some cases. On capacity building, as I said earlier on, there are three main areas of interest, and one is working with graduate fellows. Currently, we have already hired 7 PhDs, 5 MScs, and also working with bachelors in some countries. And in addition to graduate fellowships and students, we also work with communities, and we really want to enhance dissemination of knowledge, working with communities on One Health. We have some satellite stations which we want to start that work immediately. And lastly, on behavior change communication, targeting value chain actors, and that could be seen to be part of the capacity strengthening intervention. Lastly, on networks, I have a slide which follows that. And to say we started this work last year where we were mapping One Health networks in the region. And the region, of course, is sub-Saharan Africa. And we already have a live database, which we keep updating on which One Health is working where and what are their specific interests and how can ORECA work with them to further their interests in terms of their influence on the ground. So that's basically what I wanted to say about ORECA, and we have a big team of thematic leaders, and you can see in the first row on the left side, including Ashni, Delia, Lian here with me, working as leaders of these thematic areas I mentioned. Dieter Schillinger is our PI. He has been leading the development of the project ever since it was launched 2 years ago. And Hector is our communication together with Geoffrey. And Christina is also one of our coordinators who really works with our partners in Germany. Lastly, we have many graduate fellows, and we have a few there, I think, whom we have currently on our website. That's one component of the project theme leaders. But we also have a list of 10 advisory committee members who are we are very grateful for their guidance and discussions which we have to shape how we implement the activities on the ground. So if you visit our website, you'll be able to see who those advisory committee members are, as well as their contacts, and that could be a good way of learning more. So let me stop there and share with you, of course, a link for our website where you can find more material on the One Health Center. So I want to hand over back to Lian to continue describing how the conference will run. So thanks, Lian.
Thank you so much, Bernard. So just a couple of housekeeping points before we proceed. So we're very lucky that we're joined by many participants on Zoom today. And so please, those of you on Zoom, mute your mics when you join. If you're speaking remotely, please turn on your videos. For the majority of participants, we would like to capture all your thoughts and contributions in the chat function, and to note for everybody that this session is being recorded. Talking of which, I haven't heard that the voice saying this session is recorded, so can we confirm? Yes, thank you. So why are we here today, and why are we having a Kenya One Health conference? So we came together as a RECA with many external partners and felt that it was really a great time with the global focus on One Health to really showcase what is going on in this space in Kenya. But as well as using these 3 days as a showcase for One Health work, we want to use it to dig a bit deeper and start to develop a framework for One Health research that is appropriate to the Kenyan context. And so we wish to use 3 days over different topics to identify the initial elements for a demand-driven research agenda, which will incorporate aspects of capacity strengthening and really reflect the needs of the policymakers here in the country. And we'll hear from many of them on day 3. So the process, as you're aware from the agenda, we will have a combination of keynote speakers. We have selected presentations. We had a very strong showing of abstracts submitted to this conference, but we will also utilize audience participation, and you'll be introduced to the Mentimeter a little bit later, which will be one of the tools we used to capture all of your thoughts. Our messages at the end of the conference will be disseminated through a series of blogs on social media, and please see our dedicated conference website. If you want to share join in the conversation, please tweet, retweet, use these, the @Eureka_ILRI and the hashtag KOHC2021 to join in the conversation. I would really like to give a huge thanks to our organizing committee, representing multiple institutions and One Health activities taking place here in Kenya. Everyone's given a huge amount of their very valuable time to get this off the ground. And a particularly special mention to Nicholas Bohr, Rose Kellen and Jiri, Rose Manu, and Jeffrey and Jenga, who have really been a massive powerhouse behind this. And with that, I would just like to thank you and now pass on to our Director General of ILRI, Dr. Jimmy Smith, to give some welcoming remarks as we kick off this conference. Thank you. And thank you, Jimmy.
Thank you, Leanne. Colleagues, good morning, good afternoon, good evening, wherever you're joining. I'm told there are many people online, and I'm delighted that you are. So thank you. Friends, partners, and colleagues, I'm very pleased to be participating in this. I'm glad to see this happening. because I have had a strong interest in this area for a long time now. I became a convert to the One Health approach when I worked in the World Bank and had responsibility for trying to deal with the avian influenza and swine flu pandemics. Of course, the virtues of the One Health approach precedes us by many, many years. All of you who work in this area know that this term of one medicine was coined by Calvin Schwabe in the 60s, who saw the interaction between animals, the environment, and humans, and proceeded to think about this in the context of how you bring these three together to make the best of a health system that would serve all. Of course, since the days of Schwabe, the term metamorphosized into One Health, and One Health itself has had different definitions and different meanings to different people. Our definition is the one that we follow and was proposed by WHO, FAO, OIE, and UNEP. So it is a concept of delivering health at the interface of animals, humans, and the environment. It is no secret that despite the virtues which we see for the One Health approach, it has not progressed as rapidly as many of us would like. We know the virtues by working at this interface, and particularly in the context of zoonotic diseases, so much can be accomplished. In the case of ILRI and our partners, we see this not only in the context of managing pandemics or preventing them, but also dealing with the endemic diseases, which are so prevalent and so difficult for the smallholders whom we serve. So this approach of dealing with zoonotic and related diseases, not only endemics, but pandemics as well, have enormous prospects that we must continue to pursue despite the slow progress with the One Health paradigm. So the question could be asked, if you are so smart, why aren't you rich? If One Health is so good, why isn't it being pursued? And in the context of this conference, that's where I like to make a few more remarks. First of all, the issue is about funding. As you know, governments, whether they are development donors or national governments, we prioritize only the most important things we see at that moment. So when a disease comes, as this one, the current pandemic has, costing the world trillions of dollars, we're mobilized to do something about it. But as soon as the risk or the challenge abates, we move on to something else. And that's been the problem with funding One Health. We respond only to the immediacy of the threat that confronts us. I think that needs to change. And governments, probably in the face of the expenditure that they've had to make in the context of the current pandemic, will ensure that we don't have to do this over and over. But it's not just the expenditure. It is the social and other dislocations that we suffered over this period and are still in the midst as the Omicron has become evident. So hopefully funding will be more and more reliable. But the second area, I think, that militates against getting One Health going is the differing view of what it really is. And I hope that this conference will coalesce around the definition that is put forward by the organizations I just mentioned. The One Health concept elaborated by FAO, WHO, OIE, and UNEP. And it's the one we should use, I believe. Because if we use the definitions of One Health that so many others use, that includes soil health, plant health, this concept becomes so large that it collapses on its own weight. So let's keep a definition that is manageable, operationalizable, and so on. So funding the definition. The third thing that we must tackle is the disciplinary insularity that abounds in this area. The vets and the medics don't work very well together. The vets and the rest of animal agriculture don't work well together. The vets and the environmental scientists don't work together. And all of us, our discipline is paramount. I think we need to put this aside. This has been a big constraint to moving One Health. I'm sure we're guilty of this in this conference, that the vast majority of people who would be joining this conference are probably animal people. We need to get more vets, more environmentalists involved. And so this is a challenge for us as we move forward. We must break down the disciplinary insularity that abounds, because that also set up insularity at the institutional level. We need institutions that ask what needs to be done rather than what is my role in the case of an urgent pandemic. We have to get better institutional and policy arrangements and get governments working better together. We all know the dog's breakfast we're confronted with respect to the current pandemic. Every country has its own regulations about travel, coming and going. Every country approaches things slightly different. This is terrible for business and for the public. We also know that one of the big virtues of the One Health approach in dealing with pandemics in particular is that if we were able to detect diseases early, then the cost of controlling them is much, much reduced. If we were able to find out that this virus started in Wuhan and been able to contain it there, then the rest of the world wouldn't have been. And so we can say, but many other pandemics which has preceded these. Early detection is the key. Therefore, surveillance is the key. Early notification is the key. Yet, as we've seen with Omicron, the minute you notify others about a threat, they close the borders. And so who would notify anyone about something that is about to happen if the first thing that happens is punitive? This needs to stop. We need some mechanism where governments will agree about early notification, surveillance that works, help the developing countries that don't have the capability to do surveillance. And as we proposed in one of my early documents in the World Bank, some sort of a fund that is contributed to, so that countries which suffer from an early notification and other punitive measures can draw on that fund for compensate for its losses. So we have a lot of institutional work. And let me end on this point. We must act in solidarity. We cannot end whether endemic or pandemic diseases without solidarity. So we must act in solidarity. So the challenge before us that we've been grappling with at ILRI, and I know many partners are, and I hope this conference will imbibe and take forward, is that not only do we have to do the good technical work, such as perhaps vaccines in the future for family of diseases rather than individual viruses, better surveillance, better capacity building, and all the work that Oreka is going to take forward. Those are all very good technical stuff, but we also have to deal with many of the institutional challenges which I spoke about, breaking down the insularity, breaking down the institutional boundaries, working in solidarity. So creating institutions and institutional framework which help us to act in solidarity. So I'm very happy to see this conference. The potential of this paradigm is great. We need it. We know we need it. And so the work that is going to be done is critical, not only to ILRI, to Africa, to farmers, but for all of us everywhere, as we learned from this recent pandemic. So Leanne, back to you, and thank you much for the opportunity to make these few remarks at this very important conference.
Thank you so much, Jimmy, for your time and your wonderful remarks. I think it's following from that, I'm really happy that this morning we can welcome for our keynote speaker, someone who really is exemplifying the solidarity that Jimmy has so rightly suggested we need. You mentioned that vets and medics don't always work that well together, and we're now going to hear from a veterinarian who is working in a medical institution and developing vaccines which are appropriate for use across that divide in both livestock and humans. Professor George Warimwe is a veterinarian who is a PI at the Kemri Wellcome Trust Unit here in Kilifi, and is an assistant professor in the Centre for Tropical Medicine and Global Health at the University of Oxford. He has just been awarded an incredible prize by the Royal Society Africa Prize, for his work on viral zoonoses. And he's going to talk to us today about his experience as someone who crosses these boundaries and the development of a Rif Valley Fever vaccine suitable for use in humans and livestock. So with that, I would like to pass across to Professor George Warimwe, and we're really looking forward to hearing from you today. So thank you so much.
Thank you, Leanne. And I'd like to first start by thanking all the organizers for this fantastic conference. I mean, One Health has been on the fringes for a very long time, but it's now sort of center stage, and this is our opportunity to really push this agenda that really makes sense in terms of disease control. So I really like, following Jimmy Smith's talk. I mean, that's going to be a tough act, but there are some things that he mentioned about siloed thinking and in all the sort of different facets that we deal with in health. And my view of One Health in this space of vaccinology is looking at developing vaccines for humans through the lens of animal health and vice versa. So if you're developing vaccines for veterinary, for veterinary use, looking at the impact of those vaccines and the development process from a human perspective. So I'm going to talk about a program that I've been working on for a while now. So this started sometime in 2012, which tells you about the sort of scale of time that you need to develop vaccines, and also speaks to the sort of rapid development of COVID vaccines that we have seen, because that has been shrunk down to about 100 days. So it's about developing a single vaccine for use in humans and livestock against Rif Valley Fever. This audience, I don't think I need to talk about sorry, myself. Okay, I don't think I need to talk about the importance of animals to human health for this particular audience. In fact, this is a photo taken among a collection of lots of photos on the ILRI Flickr site. So I would urge you all to look at that. It's got fantastic visual representations of the importance of animal health to humans. And I like this photo because it just demonstrates the pure joy that animals bring to humans, especially children. But of course, we also know about the economic importance. There's been lots of studies demonstrating the impact of animals to livelihoods, financial security. I always mention that I was only able to go to university because my grandparents who raised me own an animal, and they sold that animal, and that generated income, some funding for me to go to university. And I'm sure there are many others in the audience who have similar stories. But one of the other things we share with livestock are infectious diseases. In fact, over 60% of infectious diseases in humans have involved an animal sort of transmission. And for the emerging infectious diseases that we're seeing now, that are increasing in incidence, that percentage is much higher. So when you're thinking about controlling human disease, it just illustrates the point that you also have to think about animal health, just because of that connection. So I'm going to talk about Rif Valley Fever, which is a virus that was identified in Kenya in the 1930s. It is an RNA virus in the family Phenylviridae. There are no vaccines available for it or no specific therapeutics, which is why it has been prioritized by the African Union and the World Health Organization. So RVF has a complex transmission cycle. By complexity, meaning that, for me, it involves quite a lot of mammalian species and lots of mosquito species. So, but the simplistic sort of explanation is that you have very heavy rainfall that causes floods, which increases the number of mosquitoes that are able to transmit the virus. That are able to transmit the virus. This increase in mosquito numbers allows a mechanism for the virus to circulate in animals. Some of the mosquitoes are infected, for life. The eggs are, if they had a blood meal that has infectious virus, the virus has, gone through its progeny through the eggs. And so the virus transmits, the mosquitoes transmit the virus in animal species, most commonly sheep, goats, cattle, and camels. And during these epidemics, where you have very high levels of viremia, viral load circulating in these animals, the mosquitoes can then transmit the virus to humans or also to wildlife. Now, the virus sort of has been detected in wildlife by way of seroprevalence studies, but the impact of RVF in livestock is really not fully understood. But in domestic ruminants, like the ones I've mentioned, you get up to about adult animals, and of course, in young animals, the mortality is much higher. This is over 90%, and the classic sort of hallmark of disease is abortion storm. So nearly all animals in a farm that are pregnant would abort. In humans, the disease is described more like flu-like illness with very non-specific symptoms, but a proportion of these individuals develop severe disease with high case fatality rates. And there's been some sort of evidence, although anecdotal, suggesting that the case fatality has been, of recent epidemics in humans has been rather high. So ranging from about 30%, at least from the East African outbreaks. So where is RVF common? It's predominantly in Africa, and these maps, are like, you would have seen maps like this for all sorts of things. Basically, the darker it is, the more cases there are or have been reported. On the left, you've got humans, on the right, you have livestock. The most important thing here to note is that there is a lot more cases of RVF reported in livestock than in humans, which possibly just illustrates the poor sort of surveillance systems in humans in some of these settings. The other thing you will note is that Kenya and South Africa, or East Africa and Southern Africa, tend to be really severely affected by RVF outbreaks, just based on the number over the previous years. So what can we do to control RVF? We have licensed inactivated and live vaccines for their use in livestock. These have some safety drawbacks, and some need multiple doses to generate an effective immune response. You need high containment for their production, because it's an actual sort of RVF virus that you're dealing with, whether inactivating it or modified in some way. And they're not DIVA compatible, so you cannot differentiate vaccinated animals from non-vaccinated animals, because the antibody response to the whole virus is similar to that's caused by natural infection. So there are no licensed vaccines for human use. And so the thrust of this program has really been about developing a vaccine for human use, but also developing safer vaccines that can be used in livestock. This is a very old table from the 1930s. Just all I want to demonstrate here is that a humoral immune response, so an antibody response, is sufficient for protection. Because of time, I won't really go into the table, but the point I want to sort of make is that if you pass into animals, again, you can confer protection, suggesting that antibodies are important. We also have, from very many studies that have been done over the years, demonstrating that neutralizing antibodies correlate to protection. And so if you're thinking about a target for a vaccine construct, you want to develop antibodies, develop a vaccine that can elicit neutralizing antibodies. And we know that if you recover from RVF infection, then these neutralizing antibodies tend to be long-lived. And this is just a case demonstrating that an individual had neutralizing antibodies up to 25 years later without exposure in the intervening period, which is really remarkable. So we know what the target of these neutralizing antibodies are. It's the surface of the viral glycoprotein of the virus. Now, these are viral glycoproteins known as GN and GC. The analogous sort of situation here is the spike protein for coronavirus. So it's like targeting the same sort of surface of the virus. It's an enveloped RNA virus. So we set out to use the ChAdOx1 platform because at that time, the ChAdOx1 vaccine platform, which is basically just a vehicle to deliver the vaccine, had been used in humans and had been shown to be safe in humans. This is very important as a sort of starting point for a human vaccine, because you've already saved so much costs by having already a track record in the safety profile. I will talk about the costs of developing vaccines later. But the ChAdOx1 platform was safe in humans previously when used for other vaccines. And all we did basically is get the targets, the genes that encode the virus, RVF, GN, and GC, and inserted this into the ChAdOx1 vector, which when you vaccinate an individual, gets into the cell, expresses the proteins, and these RVF glycoproteins then stimulate an immune response, and hopefully you've got a very high immune response to confer protection. So the methods of manufacture were already well established, so it really was a matter of plug and play. So this image just illustrates the sort of pipeline for development. It's simplistic, but it just illustrates the point. We've had the preclinical discovery period where we identified the inserted the RVF, GN, and GC into the ChAdOx1 platform. The plan was to do preclinical studies in mice and then go on to livestock trials and human studies. And if hopefully, if it all works well, then you'd have a single vaccine for use in multiple species. So the first really encouraging data we found was that if you immunize mice and expose them to RVF virus 2 months later, you had 100% protection, and this was very exciting. Whereas the group that were given a placebo did not, were not protected and succumbed to infection. So the next sets of studies in livestock were studies that we did in very close partnership with ILRI, with Vishnene and others. And the idea here was to immunize animals and follow them up for a month for immune response to develop, and then expose them to RVF virus. So this is a typical approach of evaluating vaccines. So the long and short of it was that a single immunization in all those species provided 100% protection. So none of the animals that received ChAdOx1 developed disease. And in fact, as illustrated on this plot, with the blue representing ChAdOx1 group and the black representing the licensed product and the gray representing placebo, all the ChAdOx1 vaccinated animals mounted a neutralizing antibody response. For the Rift Vax, which is available in Kenya as a RVF vaccine, 2 of the animals, one in cattle and goats, did not mount a neutralizing response and were not protected, further supporting this idea that neutralizing antibodies are the main sort of thing you need to elicit to mount an immune response. So the publication is up there if anybody wants to follow that. So the next step was to look at RVF in pregnancy, again, using a similar experimental design where you vaccinate. For this, we vaccinated early in gestation and challenged them later with a virulent virus, and then monitoring the safety of the fetus and also protection. So these studies were done in the Netherlands with Jeroen Kotekars and others, and the top panels represent the results of the vaccine development in sheep, and the bottom are the goats. So in both species, the antibody response was really very high. It was within the range we observed in the Kenyan study at ILRI. The ChAdOx1 vaccinated group in red here were protected against viremia. So you see the viral load there. It just means that the animals were protected against RVF infection. There was no illness in the pregnant animals and no sign of infection in the fetuses in sheep. In the goats, again, we had very high levels of protection, although 2 of the 25 fetuses succumbed to infection, suggesting that there might be differences in the either the mechanism of protection or other factor in goats in terms of the level of protection that you see following vaccination. But the primary aim of this experiment really was to demonstrate that the ChAdOx1 vaccine was safe, which is something that most of the vaccines currently are unable to, show. We really don't have any vaccines that can be used in pregnancy other than the inactivated versions that need multiple immunizations. So this was a really good point to sort of get that, proceed from. So the next step was to look at now that we've demonstrated the safety of the product in pregnant and non-pregnant animals and showed very high levels of protection, the next step was to conduct a field trial looking at whether the vaccine elicits a similar, performs as well as the licensed product in a study that is powered to evaluate that at a sort of population level. So the previous studies were designed to look at efficacy, for the first study, and the second one was to look at safety in pregnancy, whereas this is now looking at a field level. And these are studies that we did in Kapiti, where we looked at 100 180 animals per species. So this is with the, as indicated there, that was a study protocol. And this study was done to very high levels, very high standards, so to GCP. And I believe it's probably the largest sort of GCP veterinary trial that's been done globally. I haven't had anybody object to that in the different places I've talked about this. So as I say, the study is done in Kenya. It's in healthy non-pregnant animals, and the animals were followed up for a year. And the end point of the trial, the thing that we will use to say whether the vaccine performs as well as a licensed product, is a neutralizing antibody titers. Now, I don't have the results for this, but analysis is underway, but should be available sometime early next year. But the whole point is that this data will be used to support the registration of the product for use in East Africa and other countries in Africa where there is very high sort of exposure to RVF. So I'll switch gears a bit. So now we're moving to humans. So the veterinary development is, of course, very advanced. And we are now, at the point where we're thinking about registration. But how about the human study? So we've begun a phase 1 study in humans in Oxford. And this is the typical approach is to start with a low dose, go to a medium dose and a high dose. For any of you who've been following, the Oxford AstraZeneca COVID-19 vaccine development, you would have seen some of this sort of experimental designs or trial designs very early on. So this sort of phase 1 study is done in a small number of participants with the aim of just looking at the safety profile of the product. And of course, whether it also elicits an immune response, the desired immune response. So we already have, for the platform in general, so ChAdOx1 in general, we already have over safety database over 1 billion doses, of course, because of the Oxford AstraZeneca COVID vaccine. But now we want to add data specific to the RVF vaccine. And so far, the vaccine is performing well, both in terms of the safety and the immune response. And again, we expect this data to be ready, for sort of dissemination sometime early next year. So I've taken that fairly quickly just because of time, but the summary of this work is that we've identified very high levels of protection in livestock. The vaccine is highly efficacious and safe in pregnant ruminants. The safety and immunogenicity is expected to be as good as current licensed vaccine, which is the sort of the Smith-Ban vaccine supplied by Kevevapi. Analysis is ongoing, as is the analysis of the human phase 1 study that is going to be available as from next year. So in terms of, for the veterinary development, the veterinary use of the product, that has a clear sort of pathway that we would follow for the as stipulated by the local regulators and NBA, the Veterinary Medicines Directorate, and there is actually a harmonized process for doing this in Eastern Africa. But how about the human landscape? Now, one of the most difficult things to do, as the audience might appreciate, is to predict when the next Rif Valley Fever outbreak would be. If you are to predict that with very high sort of confidence, you would be able to design a vaccine efficacy study. So, but in the absence of that, it becomes really difficult to predict, to design a vaccine efficacy study for RVF. So an alternative approach would be to use correlates of protection as done for other vaccines. So we know, the threshold, the antibody threshold you require to provide protection against rabies, for instance, and even yellow fever, for instance. Another route is to think about an animal rule, which is something that's done by the FDA in the US. But because this is a problem, RVF is a problem that's predominantly restricted to Africa and the Arabian Peninsula. we think that there is a need to engage the regulatory national regulatory authorities in the continent about the best sort of strategy towards licensure of this vaccine, whether it's emergency use authorization, as we have seen for COVID-19, and then followed by sort of a phase 3 study where you're looking at efficacy evaluation if ever there was a massive sort of epidemic. You also need to think about what vaccination regimen is going to be eventually used. And so this relies on doing further studies, phase 2 studies, where you look at a single dose versus 2 doses and which of those performs well, and think about the deployment and how would you deploy this vaccine? Would you deploy it in humans only, or would you deploy it in humans and animals during an epidemic? And this sort of thing calls for massive stakeholder engagement, including the bodies listed there. So very much a One Health focused sort of strategy also, not just in the making of the vaccine and the planning of the experiment, but also in the future work on the deployment of the product. So I think we'll stop there. Sorry. Yeah, I'll stop there and just acknowledge that this is work that is involved very many partners, and at the center of this has been the International Livestock Research Institute, very close partners there, as I mentioned earlier. But also I cannot overstate the importance of engagement with the regulatory and policy stakeholders, including the National Biosafety Authority and the Ministry of Agriculture, Livestock and Fisheries, because this would not have been possible without their support and guidance through the process at ILRI, campus and Kapiti. So I think I'll stop there and hand it over back to you, Leanne, or for any further questions.
Thank you so much, George, for that great talk. There's lots of questions in the chat, but I'm going to just jump in with one that's maybe a little bit less technical. We talked a bit at the beginning about the difficulty of breaking down silos. So I'm going to ask you a personal question. As a veterinarian, now working at KEMRI, how have you found that transition, sort of moving from the veterinary field into sort of medical research? Have you got any suggestions for those of us here or online about talking across disciplines and forging those connections? Thank you.
Yeah, that's a good question. I mean, I think the first thing to say is I never left veterinary medicine. My background is I'm a vet, as you said, and I think I have sort of enthused colleagues at KEMRI and others, that I collaborate with globally about the value of animal health, not just from the perspective of, at the public, deployment. Because when you think of One Health, there's a big sort of bias, I think, towards thinking of control programs, like you're deploying a control programs for brucellosis, and you have to think about both. But I think I've been accusing people to think about more, even at the basic level, that there are differences in animals and humans in terms of the immune, sort of the way they mount an immune response, the components of the immune response. So you can understand pathogens and how, how to control pathogens by looking at how the host parasite or host virus interaction differs in the different species. So it's been more about showing a different way of thinking about the particular problem that colleagues are working on, and applying this sort of One Health, basically exploiting synergies in sort of immunology in both humans and livestock. It's not necessarily easy, but to me it just makes sense.
Yeah. No, that's wonderful and very sort of reminiscent of that original One Medicine concept, and also very great to hear that you never feel that you've left veterinary medicine. I'm sorry if that was what came across. I always have this myself where people said, "Oh, you're in research. Maybe you're not a vet anymore," but we're still veterinarians at heart. So I'm just going to pick up on a couple of questions that came in the chat. There was one question that suggested that given the prolonged drought followed by very heavy rains that we've experienced in the country, does this make you feel that an outbreak might be more likely? And if so, is there anything people should be considering to protect themselves or prepare?
Yeah, I mean, I think that again is a good question. There are others in the audience, Bernadette and others who can make a really informed decision based on the sort of mathematical modeling and predictions. I think I would emphasize more rather than thinking about, is there an outbreak that's going to happen because of these conditions? I think I would emphasize being ready all the time, which is something that Jimmy mentioned in his sort of introduction, that we need to be ready. We need to have surveillance systems that are ready to sort of go without necessarily sort of having to wait for a set of circumstances to come into sort of existence. So you can always, if we have surveillance systems that are full, that are not just focused on a particular disease, not just focused on RVF, then you will be able to respond quickly, regardless of whether there's a drought or whether there is not. I think I would emphasize more on having that of, everyday sort of readiness to address sort of outbreaks. I don't know whether I'm making sense there, other than focusing more just on an RVF outbreak.
Yeah, absolutely. I think that's really clear that we really need to put our efforts into preparedness and surveillance. George, I would like to just thank you ever so much. I could keep you here all day asking questions, but I do note that our time is moving on. I hope that you will be joining us through the conference. There are several questions addressed to you in the chat. If you're able to spend a bit of time and provide some answers to those, that would be really appreciated. And thank you again for your really great impact. If I could give you one more round of applause from this end.
Thank you.
I would like now, we would be moving to an introduction to the Mentimeter, but we actually have the Director General of the Ministry of Health online, who would like to give some additional opening remarks. We're very lucky that he was able to make it today. So we're just going to share his screen and hand over for a couple of remarks from Dr. Amoth. Thank you so much.
Thank you. Good morning. Good morning, everybody. Good morning, everyone.
Good morning.
Good morning.
Yeah, I'm just testing if I'm audible.
Yeah, you are audible.
Yeah, thank you. My name is Philip Ngere. I work with the Ministry of Health, the Division of Disease Surveillance and Response. I manage the Public Health Emergency Operations Center, and I also coordinate event-based surveillance. I'm here to deliver the opening remarks for the Dr. Amoth, our Director General, who is away on official duties in Zanzibar and was not able to make it for this conference physically or virtually at the moment. So if you allow, then I could go ahead and deliver his remarks. The organizers of the Kenya One Health Conference, fellow panelists, conference participants, ladies and gentlemen, good morning, good afternoon for those of us who are in the afternoon. Thank you for inviting me to this panel discussion on One Health policy implementation, focusing on the human health perspective. The One Health approach recognizes the close connection between the health of humans, animals, and the environment. For example, we know that more than 75% of emerging and re-emerging infectious diseases are zoonotic in origin. The recurrent Rif Valley Fever outbreaks and the recent findings of the Middle East respiratory syndrome, MERS-CoV, in humans are good local examples of these threats. Besides emerging and re-emerging infections, other important drivers of One Health approach include the threat of antimicrobial resistance and food safety issues. Mainstreaming the One Health approach requires a conducive policy environment. While Kenya has no One Health policy, the One Health approach is often incorporated in sector policies and plans. In the year 2020, with the support of the Food and Agriculture Organization, the Zoonotic Disease Unit conducted a One Health policy analysis. The report is due for stakeholder validation. The analysis reviewed policies, including the Constitution of Kenya 2010, Kenya Health Policy 2014 to 2030, the National Policy on Prevention and Containment of Antimicrobial Resistance 2017, National Food Safety Policy 2013, and the Vision 2030, Third Medium-Term Plan. Some of the preliminary findings show that most policies in human health, veterinary health, and wildlife sectors either have explicit or implied One Health interventions. However, the Constitution of Kenya 2010, the Vision 2030, and the environmental policies were found to lack any explicit or implied One Health linkages. The Kenya Health Policy 2014 to 2030 has 3 One Health related objectives. One is to eliminate communicable conditions. 2 is to minimize exposure to health risk factors. And lastly, to strengthen collaboration with the private and other health-related sectors. While One Health is not explicitly mentioned, the policy recognizes the importance of collaboration between sectors to enable Kenyans attain the highest standards of health. On policies and strategies on zoonotic disease control, the government of Kenya established the Zoonotic Disease Unit in 2012 through a memorandum of understanding between the Ministry of Public Health and Sanitation and the Ministry of Livestock Development. A strategic plan 2012-2017 was launched in 2012 to guide activities of the Zoonotic Disease Unit, and the strategy has been reviewed and updated, and an updated plan developed to cover the year 2021 to 2025. The updated strategy has 3 objectives: to establish structures and partnerships to promote One Health, to strengthen surveillance, prevention and control of zoonoses, and to conduct and promote applied research. On zoonotic disease control, still, several disease-specific plans have been developed in the last 10 years, and this include Rif Valley Fever Contingency Plan, developed in 2014, Rabies Elimination Strategy for 2014 to 2030, Brucellosis Prevention and Control Strategy for the year 2021 to 2040, and Anthrax Prevention and Control Strategy for the year 2021 to 2036. Other strategies that have been developed for diseases like highly pathogenic avian influenza, Ebola, Marburg, plague, amongst others. There are also policies and strategies that have been developed on antimicrobial resistance. Great strides have been made to this end in creating policy environment that fosters One Health approach in tackling antimicrobial resistance. The National Health Policy on Prevention and Containment of Antimicrobial Resistance and the National Action Plan were developed in 2017. The AMR policy was the first policy to be developed while fully embracing One Health approach. Additional policy documents include the National Integrated Antimicrobial Stewardship Plan, that's for the year 2021 to 2026, and the National Infection Prevention and Control Policy Strategic Plan for the year 2021 to 2026. Policies have also been drafted on food safety and security. The National Food Safety Policy was developed in 2013 to establish and maintain a food safety system that harmonizes interagency efforts. Various laws support safety, including the Food, Drugs, and Substance Act, that is Cap 254, the Public Health Act, that's Cap 242, and the Meat Control Act, which is Cap 316. In conclusion, therefore, ladies and gentlemen, Kenya has a conducive policy environment for mainstreaming One Health. However, developing a standalone One Health policy has benefits, as this will anchor One Health at the highest level. Alternatively, we can ensure most existing and all new policies and strategies in health, veterinary, and environment sectors incorporate One Health. Thank you. Thank you. That's the end of the remarks from the DG.
Thank you so much, Dr. Ngeri, for your interjection here on behalf of the Director General, Ministry of Health. This is really, really positive news, how strong the policy environment is for One Health in Kenya, but as you've identified, there are still some gaps to be filled. We really appreciate your time in joining us to open this conference today. I would, just before I pass to Michael Victor, I would just like to recognize the presence of several of our advisory committee members from Eureka. So thank you so much for making the time to join us for this important conference. So now I'd like to pass to Michael Victor to introduce us to the Mentimeter, one of our key audience engagement tools. Thank you very much, Michael.
Thanks, everybody. I'm sharing my screen right now. Is my screen being shared? There we go. Perfect. Good afternoon, everybody. My name is Michael Victor, and I'm the head of communications and knowledge management at ILRI. I'd like also to bring up my, my assistant here, Nicholas Bohr, who is going to actually be doing Menti with you for the rest of the conference, but I'm just going to kick it off. So, yeah. Okay. Okay. Oh, well, just say hello to everybody.
Hello, everyone, and welcome on board.
Yeah.
So we hope to have an interactive session with you all. Thanks.
Okay. Okay, great. So just really briefly, Mentimeter is just an interactive tool where we really can crowdsource ideas and really engage the audience in real time. So we're going to be using this to really ensure that the One Health conference, we really get participant feedback and engagement so as to develop a One Health research agenda for Kenya, or emerging one. And we heard from Jimmy today that One Health has many different ideas and many different kind of dimensions to it. So we want to bring everybody's perceptions and ideas together. And this is one way that we'll be doing that. So we'll have a lot of presentations, but we expect to get a lot of feedback too. So there's a lot of ways that we'll do that. And you'll see this throughout the conference. We'll be using spectrums, so you can kind of gauge how people feel across the spectrum. We'll be using word tags. will be just getting people's perceptions and ideas through open-ended questions. And then we have multiple choice. So there's a lot of ways to gauge and get feedback here. So we're going to start it out. I hope everyone has either downloaded the app, gone to the App Store and downloaded it on their phone. I see someone just going to their phone now, which is great. So you can download it on your App Store, just type in Menti and you'll get it. Or you can go to menti.com and then you just put in that code there. So it's 56857347. Okay. So our first question, we're just going to get people used to using the Menti. So an easy question. Let's see where people are from. We expect to see Kenya at the kind of right in the middle, but it'd be good to see what other countries where people are joining us from. So you start to see you can just type in one word. I think for this one, we just had one word that you could type in because people are coming from one country. So great to see. Look at someone from Bangladesh, which is great. Zambia, Malta, excellent. Australia, it must be really late in Australia. What time is it in Australia right now? About not so late? Okay. It's about 6-7 hours, yeah? About 7 o'clock at night. Okay. United Kingdom, Netherlands, Malta, excellent. How many people? So we have 74 people. How many people online? So we have 419 people online, which is great to see. Let's get it up there. Let's get people. We have 83. Let's get up to 100 at least. See where people are. We have Chris. Is that a new country? Yeah, that might be a new country. So yeah, good. Just to practice out and see if we're catching these things. I'd like to see the flag for Chris. What's the national flag for Chris? Great. Okay, we're up to 100. Is that a good sample size, Eric? 100 out of 25%? Okay. Okay, let's go to the next question. Which sector do you work in? And we have a couple of different options here: academic, non-academic research, public sector, private sector, NGO, or other. So let's see what we get. Great to see a lot of people joining in here. Let's get it up to at least 150 this time. Again, if you're trying to get on, just go to your app store. Whether you're on a Android or on a Apple, and just download Menti. It takes a couple of seconds and then input the code that's right there. Or you can go on your computer and just go to www.menti.com. Great, we're getting up there. A lot of academics. Great to see private sector. That's always a missing sector within the One Health. So it's really nice to see the private sector there. If you're from the other, put in your chat what other means. It'd be interesting to see what other means. NGO is really good. Non-academic research, interesting. Okay. So it's a good mix. It's not just all academics and researchers, which is good to see. Let's get up to 150. Great. Excellent. Okay, let's again, we're going to be doing a word cloud here, I think. What is your main discipline? So again, one of the big things about One Health is that it's transdisciplinary. So we want to see what types of disciplines we have. Is it multidisciplinary or transdisciplinary, Bernard? Trans, okay, so I got it right. Okay, good. So let's see what we have here. We have a lot of veterinarians, epidemiologists. I see a medical research, which is great. Food safety, anthropology, good. Vaccinology, sociology. So a lot from the vet side. Science communication, that's great to see. A really important part of One Health. Huh, that's a meteorologist. That's great. To weather the environment. Excellent. Program management, we need that. Product development. Excellent. Bernard, do you see, is this the type of group you want to see in a One Health approach? Are we missing anybody? Yeah. Turn on your.
We don't see many of the public health. Yeah, I think we are missing a few, like, public health. Or mainly we see epidemiology, veterinary, environment.
Mm-hmm.
Yeah.
Okay, great. I saw a molecular biologist, which is great. Wildlife health, really down below. So a little bit of environmental management to low again. We see a lot from the vet side. So quite interesting here to see, keep on going, 184, we really got up. So great. Excellent. And one more. So let's start to just get people's, you can write your own. What is your own definition of One Health? Let's see what we start to get up here. Social activism, that's great. So Shanul, you can just go back, www.menti.com. You can get back on there and put your answers there. And we'll use these. We'll be able to make word clouds from this. We'll be using this for other purposes. Okay. And, Bernard or Leon, maybe you can, if you jump in, if you see anything of interest here as well, just let us know. Okay, so using the definition from, the One Health group, it's the interaction between animal and human and the environment. Yeah.
A nice comment here on recognizing the sort of interconnectedness of all things. So everything is linked.
Yeah.
A lot of great, we see multidisciplinary coming up a lot. Integration, another great word.
Great. Yeah, seeing a lot of, so people do recognize that the real integration, interdisciplinariness, cross-sector. We're not seeing some of the other ones. We'll come up, but here we go. We're starting to get quite a few. It's the interaction, the mashup. That's a good word. It's not just the interaction, but it's the mashup. I think that's important to see as well. Let's see if we get some more moving up here quickly. A collaborative effort to achieve optimal health, multidisciplinary, deliberate collaboration. I think deliberate's an interesting word, which is good. Being deliberate about how you approach it and how you bring it together. Okay, I think we're done here. So again, Nicholas will be your mentee man for the rest of the next couple of days. And again, really try to use this because we want to build up a story and we want your participation and your thoughts and ideas to be really able to develop this collaborative research agenda and get some priorities going on from this. So really use this as your opportunity to get your voice heard. Thank you.
Thank you so much, Michael, for introducing us to Mentimeter, which we'll be all very familiar with by the end of these 3 days. So now I'm going to open up the first of our flash talk sessions for the conference. So hopefully we should hear from our pre-recorded 3-minute flash talks. Thank you so much.
Thank you to the conference organizers for the opportunity to present this qualitative work exploring the risks for urban Rif Valley fever invasion carried out in Kenya by me, Kelly Gherkin, and my colleagues listed here. So the Rif Valley fever virus is a zoonotic virus that can be transmitted by mosquitoes, but also directly to humans from infected livestock. And with this current distribution of exposure studies, it's been difficult to disentangle the role that consumption Thank you to the conference organizers for the opportunity to present this qualitative work exploring the risks for urban Rift Valley fever invasion carried out in Kenya by me, Kelly Gherkin, and my colleagues listed here. So the Rift Valley fever virus is a zoonotic virus that can be transmitted by mosquitoes, but also directly to humans from infected livestock. And with this current distribution of exposure studies, it's been difficult to disentangle the role that consumption and handling of animal products has in transmission. But in a recent community survey at our 2 urban sites in Kenya, we found risk factors were independent of livestock ownership. And despite Rift Valley fever spread and introduction being really driven by animal movement, no urban outbreaks have ever been documented. So the main objective of this study was to explore potential pathways of introduction from the perspective of those that would likely experience it first and understand how they perceive their personal risk. So we carried out focus group discussions with these high-risk groups, which included slaughterhouse workers, livestock owners, and those people that purchase blood and animal products directly from the slaughterhouse for urban distribution. And this study generated a ton of data, but just to quickly highlight a few key points. Livestock are still important for livelihoods, but with more of a focus on business opportunity. So there may be some disincentive to report. Animal products are also included in that business opportunity and are a less expensive way to consume animal protein. Blood was not just used for making sausage, but was also consumed by pregnant women and people with low iron, raw directly from the slaughterhouse. And then we also found that grazers arrived near our site seasonally, coming from hotspots like Kajiado and Garissa, and some had livestock owners that were already having mitigation efforts in place, such as removing ticks from their animals after they grazed with those animals. All of the groups, particularly at the slaughterhouse, perceived risk of zoonotic transmission to be heavily focused on hygiene, which was perceived as far superior to rural areas. And the vet's postmortem exam also made them feel that the animal products and meat must be safe. And then lastly, many participants had prior experience with disease mitigation efforts and highlighted that slaughterhouse bans are indeed devastating for them. And then on the coast, in the last outbreak, they knew that Rift Valley fever was in the county, but wasn't really seen as an urban threat. So in conclusion, we've highlighted that urban risk is different than rural risk, so may require different public health messaging and efforts to stop introduction. The high reliance on vets in connection with risk and safety means that we must give urban vets more tools and diagnostic support, because the current focus on hygiene in the post-mortem exam is an opportunity for Rift Valley fever. So we're currently exploring how we may even leverage that gap and test milk and slaughtered animal blood for Rift Valley fever to improve early detection. So thank you so much for listening to my talk. Please contact me if you want to hear more.
Hi, I'm Axon Mwale, presenting the findings of an exploratory study which focused on community participation in zoonotic disease prioritization, a case study of Nguruman in Kenya. Evidence shows that people living in remote areas near protected areas have a high risk of contracting zoonotic diseases. These communities often have no capacity to detect, control, and manage disease outbreaks. Consequently, communities rely on external help, which has succeeded in some areas but failed in others. Partly, this failure is due to lack of resources and ownership by local communities to sustain programs and lack of political support. This study aimed to understand how socioeconomic and political determinants shape community participation in zoonotic disease prioritization in Nguruman. Community participation was conceptualized by combining 2 perspectives of participation, that is, participation as a means to an end and participation as a form of empowerment. This approach was adopted to provide a holistic understanding of community involvement in disease management. Taking an ethnographically informed qualitative approach, 4 key informant interviews and 3 focus group discussions were conducted in areas around Nguruman, an area located in Magadi, sub-county of Kajiado County, southwest of Kenya. The sample consisted of 10 females and 11 men aged 18 years and above. The participants were drawn from Maasai pastoralist communities using purposive and snowball sampling. The interview and focus group data were analyzed thematically, informed by the notes from the observations obtained. Analysis of this study is still ongoing. Results show that participation in disease prioritization is influenced by professional specialization or employment in relevant fields such as veterinary medicine. Local knowledge and understanding of zoonotic diseases is only considered during implementation of interventions by experts, despite the willingness of communities to contribute to disease prioritization. Further, although determinants such as gender, socioeconomic status, policy, and external aid influence involvement in local community activities, these do not influence participation in disease prioritization. This is because of a strong emphasis on professional training as a requirement to participate in disease prioritization. It was observed that interventions implemented have not adopted a transdisciplinary One Health approach, embedding participatory methods. In conclusion, community participation in this area takes a means to an end perspective where members are used to implement interventions by experts. Local community members are not involved in disease prioritization by local decision makers and experts. This is despite their willingness to participate and their indigenous knowledge and experience in managing zoonotic diseases. As a result, community members feel that important aspects about local context and control strategies are not considered in many interventions, as they are not given an opportunity to give feedback and input in what works to inform policy. A transdisciplinary One Health approach should be implemented, embedding participatory methods throughout the process. Thank you so much for listening.
Thank you very much to those people who pre-recorded flash talks, and we will return to the rest of those flash talks later, but we will move on now because we were a little bit late, so to allow our in-person speakers to present. So I'd now like to introduce you to Dr. Katie Hamilton, a parasitologist working with the University of Liverpool and ILRI, who would like to talk to us today about antimicrobial resistance in slaughterhouses in Brucella. Thank you, Katie.
Thank you, Liam. So as Liam said, I would like to talk to you about a study that was performed by many of the people who are online and who are sitting in this room on antimicrobial resistance in a slaughterhouse in Western Kenya. Now, I know all of you in this room know how to define One Health, but what I would like to do is to add another aspect to it. I would like to introduce the food chain alongside the traditional humans, environment, domestic animals, and peri-domestic wildlife. So as you're all aware, antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites evolve over time and no longer respond to medicines, making infections harder to treat and increasing the risk of disease spread, severe illness, and death. And during this study, we focused on E. coli as an exemplar emerging pathogen, which exists in a diversity of hosts, in the environment, on the food, and in waste. It can be a harmless gut commensal, but it can cause some pathogenic strains and cause life-threatening bloodstream infections and common illnesses. E. coli can also cause diseases in animals, leading to severe economic losses due to mortality and morbidity. E. coli was categorized by the World Health Organization as a priority pathogen due to its widespread antibiotic resistance. Slaughterhouses are considered hotspots for pathogen and AMR transmission, given the frequent interactions between the people who work there, the animals, and the surrounding environment. This creates a risk both for the workers and for the people who consume the meat products. Therefore, slaughterhouses are optimal sentinel sites for surveillance and also for intervention studies, given the ripple effect that they have on other sectors. The objective of our study was to conduct a microbiological assessment of the slaughterhouse's working environment and to engage in different stakeholders' discussions on AMR. The ultimate goal of the project was to obtain a baseline study of the AMR landscape within the slaughterhouse setting, and to then use this information to develop relevant AMR educational material. Now, our study was part of a much larger study called ZooLink. And ZooLink went out to do a surveillance study for emerging zoonoses. And they had set up 12 sentinel sites within 3 counties within Western Kenya. Now, each of these sentinel sites had to have a livestock market, 2 or 3 slaughterhouses, and a hospital nearby. As you can see, we wanted to study slaughterhouses, and the top picture shows an informal slaughter slab, and the second one below shows a more organized, larger slaughterhouse. And these are the types of slaughterhouses we were working with. For the microbiological assessment, we took biological samples from each slaughterhouse. We sampled the floor using the boot socks in the first picture. We sampled the equipment that was used in the slaughterhouse. We took swabs from the inside of a dressed carcass and the outside of a dressed carcass. We took some water that was used for washing. We asked the slaughterhouse workers if they would mind if we took a handprint. And we also sampled the meat box, which is where the carcass from the slaughterhouse gets carried and delivered to the butchers. During the same time, we also held stakeholder discussions. We first held a focus group discussion with the county veterinary officers, the sub-county veterinary officers, and the meat inspectors. And during these discussions, we explored stakeholders involved in antimicrobial resistance within the slaughterhouse context, factors driving the AMR, and the challenges dealing with AMR. We next organized a series of workshops for the slaughterhouse workers in the 3 counties. With them, we explored which drugs they commonly use, why they use them, and had they ever experienced treatment failure? And if so, why did they think this had happened? So now the results of the biological sample. We collected 193 samples from 13 slaughterhouses. 9 of those were ruminant and 4 of those were pig in 11 of the sentinel sites. We identified isolates in just over half of the samples. There really appeared to be no difference between the pig and the ruminant slaughterhouse samples. And the highest proportion of isolates in the samples came from the carcass, the boot sock, and the meat box. Then we went on to do antimicrobial susceptibility testing on 98 of the isolates. 21 of those were from pig, and 77 of those were from ruminant. On average, the isolates were resistant to 3 of the 14 of antibiotics tested. The results indicated that the isolates were most commonly resistant to streptomycin, ampicillin, tetracycline, and trisulfur. Multiple drug resistance is when an isolate is resistant to 3 or more classes, and in this case, over 51% of the isolates tested were. Again, there was no significant difference between the isolates from the ruminant and the pig slaughterhouse samples. And the highest portion of multiple drug resistant isolates were again from the boot sock. Extended spectrum beta-lactamase are enzymes that confer resistance to most beta-lactam antibiotics, including penicillins and cephalosporins. We found this expressed in 16.3% of the isolates tested. The samples with the most ESBLs were the boot sock and also the meat box. Now, the boot sock represents the environment within the slaughterhouse. So this is significant. I mean, some of these slaughterhouses, it gives an indication of what is going on within the slaughterhouse. But there was no difference between ruminant or pig. So it just appears as if there's one large soup just mixing around within the environment. Through the focus group discussions that we held, we identified the stakeholders that really play a role in antimicrobial resistance within the slaughterhouse setting and how they relate to each other. Now, butchers emerged as prominent stakeholders, as they are often the ones who bring the animal to the slaughterhouse and then again take the carcass to the butchers. Butchers emerged as individuals who can exert a lot of pressure, to the point where some individuals complained that they couldn't actually do their work properly due to the pressure that the butchers are putting on them. We believe that we can use the butcher's influence and leverage it to positively influence and educate other stakeholders. The inadequate use of drugs was recognized as a reason for the increase in driving resistance. This included the under or overdosing of animals, not respecting withdrawal periods, and the indiscriminate prescription by professionals, such as medics and vets. And this was highlighted by one participant who said, if we vets also continue looking at all animals like they are antibiotic deficient, that is the disease we treat. This problem will continue to escalate. Major challenges in dealing with AMR within a slaughterhouse setting is related to the limited staff and the inadequate funding, which leads to underinvestment in the infrastructure and the equipment. Many of the individuals who work in the slaughterhouse, they don't have any protective clothing of any sort. There is limited availability of water. The perimeter fence, which is important for biosecurity, is often missing, and waste disposal is sometimes indiscriminate and just spread into the environment. When we queried what the workers thought of AMR situation in the slaughterhouse, they said they had no idea, as there was no laboratory capacity to detect or surveillance to detect any changes in AMR. Everyone did agree that antimicrobial resistance requires a multi-sectorial approach involving many stakeholders. This can be very challenging to coordinate, but they did appreciate that the medics should be involved for public sensitization, as they're the ones that carry so much respect within the community. A national action plan on prevention and containment of antimicrobial resistance was launched in 2017. The results, and part of this national policy, is to involve all stakeholders. The results from our stakeholder meeting indicated there needs to be a better coordination with the people who are trying to introduce the action plan to the people on the ground to ensure that there's a proper implementation and control of antimicrobial resistance. When we spoke to the slaughterhouse workers regarding drugs and what they take, they admitted quite freely that they often just use self-diagnosis and only go to hospital or seek medical advice if there is any case of complications. They admitted that they had experienced drug failure in humans, mostly antimalarials, and in animals, ectoparasitic and helminthic drugs haven't worked. Drugs are freely available on the markets, in the streets, and in the small corner shops. That fact, coupled with a lack of formal advice, leads to an unquantifiable amount of use of antibiotics in animals and humans. One of the most popular antibiotics purchased for humans was amoxicillin, and for animals was alleamycin. When we queried the reasons for resistance, the slaughterhouse workers knew that there was a germ that causes disease, and it is transmitted. They were also aware that they needed to take the drugs, but the reasons why they never finished the courses was lack of money, incorrect drug use, and fear of side effects, and also the fact that they were feeling better. So why do I bother finishing my course? As one individual said, sometimes you visit the chemist or clinic where a dose is prescribed for you, but you don't have enough cash. So maybe the drugs cost like 600 and you have 200. So because the doctor wants money, they tell you to go with the little drug and ask after how many days will you get the money? You tell them tomorrow. You take the drugs for a few days and notice a change, then stop, which also contributes because you have not finished the dose. We found that many people who worked in the slaughterhouse were aware that they were at a risk with the work that they do to disease transmission. As one slaughterhouse worker said, so maybe there are diseases that affect the animals and is undergoing treatment. The animal is taken to the slaughterhouse without completing the treatment. When slaughtering the animal, there is the interaction between human and the animal. In case there are injury to the human, there may be mixing of blood of the animal and human blood, and hence we can also be affected. Hygiene was an area that the slaughterhouse workers were completely aware was important in dealing with resistance. Both personal hygiene, for example, washing hands and clean clothes, and at the workplace. They recognized the importance of education in understanding and mitigating the risk, as can be seen by the quote on the slide. Educate us on how we would be handling maybe the meat before it reaches. Which other ways are we handling where? Educating us on getting a knife, cutting meat, how to hang the meat so that it doesn't get bacteria from the ground. Like you said, dust usually contains bacteria. So you educate us before undertaking the work. As part of the study, we developed an educational video that we produced and shared with all the participants taking part in the study. The video was so well received that the government of Kenya endorsed it by including their coat of arms at the end of the video. Public health messages are important, and our work we are doing here directly informs the implementation of the national strategy. I would just like to say thank you very much to Eureka for organising this and allowing me to highlight my work, and all the people who were involved in the study and everyone who funded this. Thank you very much.
Thank you so much, Katie. So I would firstly like to thank you for that great presentation, but secondly, put you on the spot a little like I did to George earlier, and just ask you about some of your experiences working in a multidisciplinary team, and anything that you would like to tell the participants about how best to sort of undertake One Health research.
I think with our One Health research, because as I said at the very beginning, it incorporated the food systems as well. So I've added another factor to it. I think that we were very lucky. Everyone was very keen and wanted to be involved, but there were key players who we missed out. And I think when you undergo research, do in a One Health situation, like we all should do, you have to do your groundwork and make sure that nobody's missed out. By that, I mean, we should have incorporated the butchers when we were doing our stakeholders meetings, but the key person wasn't highlighted as an individual of prominence until we started discussing. So it's slowly build. So I think does that answer your question?
That's great. So there was a sort of iterative nature in building your sort of research question and the people you were working with. That's great. And thank you very much for highlighting the educational video. I would like to ask if you could put the link to that in the chat so that everybody can easily access that. That would be wonderful.
I will do.
Thank you so much. Okay, another round of applause for Katie.
Thank you.
Now I would like to invite Dr. Michelle Kasudi to join us. Michelle is a veterinarian at the University of Nairobi and was an intern here at ILRI in the Animal and Human Health Program. And she would like to tell us today about her work in Nairobi. Thank you so much, Michelle.
Thank you, Leanne, for that introduction. So, yes, so my name is Michelle Kasudi, and I will be presenting on work on a study that I did with Dishon Muloi and Eric Favre on integrating ecosystem and public health into urban planning, a case study of Nairobi City. So I'll begin with a definition of urbanization. This is the population shift from rural to urban areas. In other words, it is the process through which cities are formed. And here we can see the numbers of urban population worldwide from the year 1980, which was 39%, and in 2015, it rose to 54%. And it is postulated that by 2050, the number will rise to 66%. And just where are these urban residents going to reside? Our research shows that 1 in 3 urban dwellers live in slums or informal settlements. As you can see in this image, it shows a wealthy neighborhood next to informal settlements, and we can see the disparity and inequality that directly affects the health of urban residents. So what can we use to measure the health of urban residents? These are some of the determinants that can be measured. We have physical housing, health services, food systems, air quality, among others. And after looking at these and doing an in-depth research on urban health, we discovered that there are gaps in urban health. And these include weak linkage between urban planning, urban health, and urban biodiversity. There is minimal interaction and coordinated effort among stakeholders. And then there are weak integrated surveillance systems to monitor and survey these determinants of health. And in an attempt to address these gaps, we decided to develop an interdisciplinary project on urban ecosystem health, incorporating urban planning, ecology, and human health. So we decided to use Nairobi as the location for this study because it is an ideal depiction of a rapidly urbanizing city. 60% of its residents live in informal settlements, and it has high infectious and non-communicable disease burden. In the image on the right, we can see an interesting relationship between a country's gross national product and the mortality caused by infectious disease and non-communicable disease. You can see that as the GNP increases, mortality caused by non-communicable disease increases, while that caused by infectious disease decreases. We also have here an article from The Conversation about how Nairobi is rapidly losing its green spaces, which could lead to increased disease incidence. So the approach that we used, we did an in-depth literature review on urban health. And then I developed a theory of change which helped guide and map the work. Then the next step was to identify relevant stakeholders through internet searches, then contacting the stakeholders, that was through emails and phone calls, and then have key informant interviews to generate data on the different systems. And in these interviews, we use the snowballing approach to identify other key partners. So 30 institutions were identified and 18 responded so far, and 12 meetings have been done with representatives from each sector. We divided the institutions into 4 categories, that is research institutions, urban planning, public health, ecosystem health. And as we can see in the graph, in the charts below there, that is how they were divided. The data analysis plan involved data collection, transcription of the meetings, a thematic analysis to draw out major themes from the interviews. And then, since this is an ongoing work, we plan to generate and validate hypotheses with government planning authorities, and then test these hypotheses in the field and in the lab. So this is the theory of change that I came up with. It states the problem, which is lack of relationship between urban planning, ecosystem health, and public health. Then the main goal, which is to institutionalize operational linkage, not just because we are aware that there are linkages that exist, but we want to make sure that they are operational. So our long-term goals include creating new and strengthening existing collaborations and partnerships amongst the stakeholders, empowering Kenyan researchers and planning authorities on the created collaborations, and also strengthening urban ecosystem surveillance systems, and ultimately contribute to sustainable human settlement planning. Our short-term goals, I'll just mention a few because of time. Identification of stakeholders, which we already did. Another like stakeholder capacity building, which we plan to do, and setting up of surveillance systems. These are some of the assumptions that we have as we do the work. For example, that the partnerships that are formed will be sustainable, and that the planning authorities and policymakers are willing to adapt research into their decisions. And then some of the indicators that we have, the surveillance frameworks that are created, and evidence of synergies between the stakeholders. So after doing transcription and thematic analysis, these are some of the themes that were emerging. We have weak coordination. 75% of the respondents stated that there are clear individual roles and existing partnerships between the urban health sectors, but there are ill-defined linkages between the sectors. One of the respondents stated that, and I quote, "Water is far from health," which essentially means that they believe that water supply has no relation to health outcomes. Another theme was competing priorities. The respondents stated that there are competing priorities that might be caused by sometimes, in some cases, some stakeholders are given tokenistic roles in projects, while others are given disproportionate influence on planning decisions. Then there's the theme of minimal operationalization. The respondents state that frameworks for urban development and policy exist, but there is poor implementation. This can be caused by, for example, changes in governance, which cause changes in priorities, and then it leads to a delay in implementation. There's also little accountability caused by, there's limited platforms to which, through which the implementers can be held accountable for their inaction. And then funding, one of the respondents stated that they have a challenge with financing, which causes a delay in implementation, while another stated that stakeholders are too dependent on international organizations for external funding instead of taking the initiative for urban development. Then we also have weak research policy interface. Most of the respondents agreed that research is incorporated into urban planning decisions, but there is also, that comes with weak implementation, which causes a challenge. There are also unintegrated surveillance systems. So currently, we only have 3 urban demographic surveillance systems in sub-Saharan Africa. One of them is in Ethiopia, the other in Burkina Faso, and we have one right here in Nairobi. The Nairobi Urban Demographic Surveillance System has been operational for the last 18 years and is run in 2 slums in Nairobi, and it collects information on main demographic events, health, and socioeconomic outcomes. Another concern was COVID-19, where the respondents were concerned about how we can sustain the responses to COVID, to other outbreaks, and how we can plan our cities for outbreak response. So this is just another illustration of the different responses from the different sectors. On the y-axis, we have the respondents in percentage. On the x-axis, we have the different sectors, and the bars represent the different themes. So we can see that weak coordination and research and cooperation was mentioned by respondents from all the different sectors. And interestingly, the research sector did not mention a challenge with implementation. And then we can also see that only the research sector and the ecosystem health sectors have active urban surveillance systems. So our conclusions for this work is that there are weak linkages existing within the urban health sectors. There are challenges with implementation, and operationalization of policies and frameworks. And there is need to form new and strengthen existing urban health surveillance systems. Our recommendation would be to adopt a holistic approach to urban health and establish central coordination for the stakeholders, the different stakeholders, that is vets, ecologists and scientists and urban planners also, to be on the same page and have clearer goals. Our main goals, as I mentioned in the theory of change, are in line with the Sustainable Development Goals. We have SDG 17 to promote implementation and partnership, SDG 11 to make cities and human settlements inclusive, safe, resilient, and sustainable, and SDG 3 to ensure healthy lives and promote well-being for all. So our future work involves having a series of meetings and workshops for further stakeholder engagement and also for capacity building. And through these meetings, we can have focus group discussions where we'll generate and validate hypotheses. And then we'll hold a major stakeholder meeting where we can build a fundable research program. I'd like to acknowledge the funders of this work, UKRI and GCRF, and everyone else who made this work possible and supported it. Thank you.
Thank you so much, Michelle. That was absolutely fascinating talk. And I'm really sorry that due to our time constraints, most of your questions will be followed up in the chat, if that's okay. But I'm sure I'd like to just direct one thing to you. I'm sure that you might have seen some missing stakeholders in our Menti session. So do you want to reflect on the participants of this meeting and anyone you see are missing?
Sorry, can you repeat?
Did you notice any disciplines missing from this meeting when we looked at the participants earlier in Menti?
Well, in relation to the work that I'm doing, I didn't notice any urban health, any from the, urban planning sector. So maybe you can incorporate them because we are trying to have a plan for sustainable futures, sustainable urban planning for future health. So I think to include them in this One Health approach would be important.
Thank you. Yeah, I think this was the first time I had really considered this, and it was a real eye-opener. So thank you so much for your talk today. I'd like now to pass to Nicholas Bohr to take us through a brief Menti session before we finish our flash talks and have a break for lunch. Thank you.
Yeah. Oh, it's fine. Yeah. So thanks, Leah, and all the presenters for today. And we'd love to engage the audience now on Menti, having listened to, first of all, the welcoming talks and the different works that they're doing. So maybe you can switch gears to Menti to give you a chance to listen in and share your contribution. All right. Yep. Ford. Next. Yeah, so let's hear from the presentation that you've had today, some great examples that you've seen on One Health and why. You can put in on Menti that discussion. Yeah, they're coming in, AMR. Yeah. Also say why you saw them as great examples of One Health. Yeah, we see the integration of the slaughterhouse workers, which is good. Always good to involve them. RVF also in terms of vaccines for humans and animals, not only animals. Yeah, we see more research coming in. RVF, AMR. Yeah. How many people do you have? 36. Keep them coming, keep them coming. Yeah. Yeah, AMR. I think we've not had a lot, but we'll hear a lot of talks as we move along. How many? We are at 67 now, 68. I hope people have not logged out for lunch. Yeah, AMR. Let's go to the next one. Yeah, what are some of the aspects of One Health that you saw that were missing, especially now that we mentioned that One Health is collaborative in nature? Oh, gender, good, good. And we'll be talking about gender in tomorrow's session, gender in One Health. Yeah, some are saying it was well incorporated. Good work, Katie and Michelle. Climate change, environment has been superficially mentioned. One Health in Abattoir is a good example. Wish there were more MDs meeting. Wildlife. Yeah, maybe you can mention maybe in which talk did you feel like wildlife could have been incorporated? Yeah, I hope not at the slaughterhouse. We don't want to see wildlife meat in the slaughterhouse. Yep, plant health. Epidemiological modeling, social economic status here. We saw that AMR can be a driver when people don't have a lot of cash. Breaking professional barriers, very important. Yeah. All right. All right. So thanks so much. We'll still have more chances as we move on with the conference. So I think thank you very much to our audience. Now we are going to break for lunch. Come back at 1:45 at 2, Leon, right? Yeah, 2. Then, yep. All right. Thank you. So, and then we'll hear more of the flash talks when you come back. Thank you very much and see you all at 2 p.m. Flash talks now? Yeah. Okay, so IT, maybe you can share the flash talks before you go. All right, the remaining.
Thank you to the conference organizers for the opportunity to present
my presentation. I'd like to
give feedback and input in what works to inform policy. A transdisciplinary One Health approach should be implemented, embedding participated methods throughout the process. Thank you so much for listening.
Hello and welcome to my presentation. I'd like to share with you some of the findings we have with regards to antimicrobial use among pastoral communities in Kenya. As a background, we understand that antimicrobial resistance is a serious public health problem both locally and globally. A lot of research has already been conducted on antimicrobial use, especially in large-scale production systems and in developed countries, with minimal research done in low and middle-income countries, especially in pastoral production systems. And so we undertook this study to understand how these communities make decisions on antimicrobial use, given the fact that pastoralists actually contribute a major component on our beef production value chain, especially here in Kenya. This presents a good opportunity for any intervention that would need to be done to mitigate antimicrobial resistance in the food value chain. We sought to understand what factors influence the decisions that are made with whether a herd is treated with antimicrobials or not. And we collected data using a community-based animal health survey that included herd health practices, vet services access, and vet advice access as well as other herd health management practices in this household next to the Masai Mara National Reserve. This was a very fertile study site for human-wildlife interface and livestock-wildlife interface, again presenting a very good One Health study area. We subset factors into 6 thematic areas, as you can see depicted here, and all of these were to help us identify antimicrobial use trends on different herds. And to understand antimicrobial use in the different herds, we then defined our outcome as AMU in different species, that was cattle and sheep and goats separately, and also used disease-based models, which were FMD and OFF models. We then ran a multimodal logistic regression, which is a supervised machine learning approach to identify factors that popped up as highly ranked in the different models. And as you can see, there are factors that in all the 4 models came up as important factors in antimicrobial use trends in this community. In a nutshell, we identified the gender, education of the respondent, occurrence of CBPP and tick-borne diseases, as well as use of some vaccines, and access to vet services and advice are critical components when it comes to decisions of antimicrobial use among different herds in these communities. Thank you, and I'm happy to take any questions.
Hello and welcome to this presentation. My name is James Sakoko. The title of my presentation is Molecular Epidemiology of Brucella species in mixed livestock human ecosystems in Kenya and Tanzania. Brucella species cause infection in animals and humans and results into socioeconomic losses. Several studies have reported the presence of Brucella antibodies in Kenya and Tanzania, but information on circulating species of Brucella within the region still remains insufficient. Therefore, we collect a total of 1,571 samples from cattle, sheep, goats, camels, pigs, and humans from Marsabit and Narok counties in Kenya, as well as northern Tanzania. We extracted DNA from these samples and tested the DNA for the presence of the genus Brucella, as well as Brucella abortus and Brucella militensis using real-time PCR technique. Our results shows that Brucella abortus and Brucella militensis are circulating in human population as well as all the livestock species except pigs that only tested positive for Brucella abortus. The distribution of Brucella species varied across the different regions, with northern Tanzania and Narok having a higher proportion of Brucella militensis as opposed to Brucella abortus, while Marsabit region had a higher proportion of Brucella abortus. We did not find any significant association between Brucella abortus and sheep and goats, while Brucella militensis didn't have any significant association with cattle. We found significant association between occurrence of abortion and the presence of Brucella abortus, while Brucella militensis was associated with retained placenta in animals. People within the age category between 21 and 40 had an elevated positivity rate. This is mainly due to their increased role in taking care of animals. So in summary, we found zoonotic species of Brucella circulating in the different animal species, suggesting that all these animals could be playing a role in transmitting Brucella to humans. Therefore, we recommend a multidisciplinary approach that target all the different livestock species to help in creating public awareness and contribute to the reduction of the existing risks such as improper handling and disposal of aborted materials, retained placenta, drinking of raw milk, as well as mixing herds that could perpetuate the transmission of Brucella within the population. Otherwise, if nothing is done, then we still have continued transmission of Brucella that results into socio-economic losses. Thank you very much for your attention.
My name is Titus Mutwiri, and thank you for inviting me to share my work through this flash talk in this conference. My work was on distribution and genetic diversity of cystic echinococcosis in a non-endemic region, and that is Western Kenya, a One Health approach. And cystic echinococcosis is a disease that causes significant public health problems in areas where there is uncontrolled slaughter or in places where livestock keeping is extensive. And this disease has not been previously reported in Western Kenya, but there has been continued and increased movement of livestock from areas of high disease density to regions of low disease density, and this has amplified the risk of its introduction to a non-endemic region. We have found many cysts in slaughtered livestock. We have conducted molecular analysis in these cysts and confirmed all of them to belong to Echinococcus granulosa sensostricto, which is the sheep strain of the parasite, but now found in different other species and cattle in our case. Through sequencing, we report 11 haplotypes of NAD1 gene and 19 haplotypes of COX1 gene. And some of these haplotypes are novel and have not been previously reported elsewhere. This has shown an expression of intraspecies variation by genetic drift or selective response, and we are following up to see the effect of these genetic changes. We surveyed dogs in Busia and we surveyed dogs in the Bungoma counties and found one dog with a superinfection of Echinococcus granulosa centennial species, which was confirmed through a PCR restriction fragment length polymorphism. And on the human component of the study, our human screening survey that involved 1,002 participants identified 7 patients with presumptive cystic lesions recommended for follow-up according to the World Health Organization classification and recommendation. We find that cystic echinococcosis is transported by routes of animal trade to Western Kenya, and that dogs pick up the parasite from poorly condemned offal. Human evidence is not currently definitive because this is a slow disease. However, if the risky practices continue, then human infections may be realized and confirmed soon. There is a need for controlled
Unfortunately, it seems that Titus has got cut off. So do you want...
realized and confirmed soon. There is a need for controlled.
What a shame. I would love to hear the end of Titus's talk. But thank you everybody for your participation this morning. Those of you in person here in Nairobi, I'd like to invite you to come for lunch. And for those of you online, please have a break and come back fully refreshed. We start again at 1400 hours East African time, and we look forward to seeing you at that point. Thank you. Bye.